second year of the Building Trust Essay Contest, which is a jointly sponsored contest by the ABIM Foundation, as well as the American Medical Student Association. And this year's students who applied and submitted essays were asked to write about an experience they or someone they know experienced in healthcare around the issue of mistrust.
I set the microwaved cup of instant coffee down on the table so hard that it sloshes. He looks at me with guarded eyes. Despite trying to stay positive, this is not exactly an ideal start. Working with refugees seeking asylum in the U.S. has taught me that trust is not easily won, and nor should it be. For someone who has lost so much to tell you the stories of their lives, it requires the willingness to try establishing a connection over and over again. David, you need a root canal due to the deterioration of your teeth. I explain the procedure to him and its importance to his health, but he shakes his head vigorously at me to make me understand. No, they will sell my teeth to the government. They will use it to frame me for a crime I didn't commit. David's fears are far from unfounded. His deep mistrust of the medical system is born from experiences in his home country, where the government would arrest people for crimes they didn't commit, and medical providers would turn over patients to the police. His misinformed beliefs are rooted in conversations with other refugees who have warned him that people may pretend to help him only to send him back to his home country. He has little reason to trust me after a few hours of meeting over the past few weeks. My eyes settle on his knuckles glowing white as he clutches the styrofoam coffee cup. I soften my voice. David, I know it is scary. This procedure is completely safe. All they will do is... He cuts me off, exclaiming in frustration, "No, I already told you I don't want it." Instead of immediately responding, I take a moment. My mind drifts to my niece, remembering her eyes brimming over with tears as she told us that she didn't want to go to the dentist because she was afraid it would hurt. We showed her a YouTube video explaining what each of the tools did until her tears subsided. Maybe combating misinformation isn't just about the information itself, but finding the best way to communicate it to another person. I pull up a video on YouTube explaining David's procedure. I watch as his tense shoulders relax, settling into gentle curves just as the frown on his lips settles. I ask, a little too cheerfully, "So, what do you think?" He looks at me for a moment. He is still unsure, but I can see his grip on the coffee cup loosening. I allow myself a moment to hope. Not today, I think. David hitches the jacket over his shoulder as he prepares to leave the appointment. I feel the familiar stone of disappointment settle in my stomach as I shuffle the stack of papers stained with coffee. David pauses at the door before he leaves. "Next week?" he asks. "Next week we can watch the video again?" I smile wider, nod. "We can watch the video again next week. Maybe I'll even write a song to convince you." David nods back at me. Not exactly a smile, but an affirmation that we will try again next week, and the week after, and as many weeks as he will allow me try to earn his trust. And now, I wish I could tell you that the story ended with a clear success, but David and I are still working on him getting the procedure. We continue showing up week after week, trying to meet each other in the middle. Misinformation is a door that offers a peek into the corners of another person's mind. Although these conversations may be fraught with tension and disagreement, they're also an opportunity to understand more deeply. Building trust is a series of small steps that doesn't always arrive at a clear solution. Although these appointments may not always have the outcome that I hope for, they're just as valuable as ones where mutual trust comes easily. I believe the most difficult piece is accepting that agreement is not always promised. My first months of medical school were energized with the idealism that I could win over every patient. Now I have a more subdued approach. I sit beside the patients. I listen without judgment. I wonder about the amalgamation of life experiences that have led them to their ingrained beliefs, value systems, and this very conversation. I do not pretend to have all the answers. Perhaps this is ultimately what draws us together. Even at odds, reaching out across a vast divide, we can all acknowledge that we are just doing our best to find meaning amidst the messy beats of life, so that even if our conversation doesn't end with agreement, a handshake, or a root canal, there is a promise to keep reaching across the divide, listening and sharing stories over a lukewarm cup of coffee.
A sneeze issued from the tent as we approached. "Anybody home? Street medicine outreach," my preceptor called out. The tent's mouth unzipped, revealing our patient, a young man. My medical school has a street medicine team, a collection of students and preceptors who work on the streets and in shelters, providing medical care to individuals experiencing homelessness. This tent was tucked away behind a grocery store, partially shaded by a dumpster. I knelt down, offering a cup of coffee. "How are you today?" Our patient shook his head. "Not so good," he coughed. He'd become ill yesterday. Fever, malaise, sore throat. He'd had a meal 4 days previously at a soup kitchen, one our team knew to be the site of a recent COVID-19 outbreak. I asked if we could offer him a COVID test. Our patient looked up sharply. "Nah," he said. "That COVID thing is a hoax." Immediately, my heart began to beat with agitation. To me, this felt like a provocation, the presentation of false facts, my own knowledge questioned, and of course, the public health ramifications of his belief. How dare he claim COVID was a hoax? A recent Kaiser Family Foundation report found that 78% of those surveyed, quote, believed or were unsure about at least one false statement, unquote, related to COVID-19. COVID-19 misinformation has created a second pandemic. What has resulted is loss of trust in our scientific institutions, failure to evaluate credible information, and a lack of agreement among neighbors on even the most basic set of facts. COVID-19 misinformation is, quote, a powerfully destructive force. One false idea can spread instantly to many vulnerable ears, unquote. But while it is true that misinformation is a tremendous burden to our public health, so too is the way that we speak of those who espouse it. We shake our heads at the ignorance, lament the selfishness of those who reject medical recommendations, effectively creating silos of us versus them that pit clinicians against patients. Infrequently do we attempt to understand the lure of misinformation. It is not often that we stop to consider how misinformation may make sense to those for whom our healthcare system has not traditionally worked well. Our patients experiencing homelessness have good reason to mistrust the healthcare system. Unhoused patients contend with profound bias, stigma, and mistreatment in our medical institutions. So too do our patients of color. We have yet to demonstrate in healthcare or society that we value the lives of our Black, Indigenous, or Latinx patients. Misinformation results from a fundamental lack of trust in one another, a breach in our ability to communicate respectfully. Mitigating misinformation can only begin when we endeavor to understand its origins. In her book, I Never Thought About It That Way, Monica Guzman makes the case for changing our approach toward those with whom we disagree. Instead of attacking one another on the merits, or perceived lack thereof, of our arguments, our inability to communicate with one another must be the starting point to engagement. We must be curious about those with whom we disagree. We must approach misinformation the same way. In my own life, I have witnessed the destructive power of false belief. A close family member refused to be vaccinated for COVID-19 subsequently failing to meet my son for over a year after his birth. I have a parent who struggles with the neurologic effects of long COVID, frequently tasked with convincing others that their symptoms are real. As I try to navigate how to keep my children safe in a world ready to move on, I meet unvaccinated patients in the clinic and on the streets who tell me that COVID is a hoax. I am often terrified by the hold misinformation has on our communities. But I have learned enough from my mentors and my patients on the streets to know that building bridges back to healthcare and to community is hard. Building trust, both within our hospital walls and at our dinner tables, on the curb or in the clinic, requires patience, grace, and yes, curiosity. Guzman offers us this advice, quote, "When you want to stop listening so that you can react or respond or judge, mind the gap between what you know and what you most certainly don't. And ask one more curious question. We must attempt to see one another before we attempt to change one another." I face my patient and take a deep breath. I said, "Tell me more."
Are you sure? The question was addressed to the physician in the room, but his gaze was on me, like he was looking for a second, differing opinion. If we're being honest, I'm usually not sure. The amount of information available at our fingertips can be overwhelming. As a first-year medical student, I often struggle to trust myself, but I trust the process of my training. Since starting my preclinical years, my knowledge base has been tested, stretched, and built upon at an exceeding rate. Every other Tuesday, I get to see real patients, practice interview skills, and apply new material through a clinical mentorship program. It is in these encounters that I learn about more than the organ system of the week. It is in these encounters that I witness fear and vulnerability turn into trust. It was also in one of these encounters that I first met Sergio. Sergio was a year younger than me. He was wearing glasses and a hoodie. He had his phone in his hand and his backpack propped up against the exam room table. We hit it off right away, but I could tell that he was nervous. A week prior, he was helping a neighbor with a construction project when he inhaled some dust and debris. The exposure was brief and limited, but he was nonetheless concerned. He read online that vigorous exercise was the best thing he could do to clear out his lungs following exposure. Not only did it not help, but for the first time in years, it exacerbated his asthma. The next day, he woke up with a new pain in his back, right around where his lung would be. I've been trained to ask patients what they think might be causing their symptoms. You can learn a lot with this question, like their spiritual or cultural beliefs around illness. It can shed light on their past medical history, family history, or prior healthcare experiences. Most importantly, it gives patients a judgment-free space to share their concerns, something they might have heard, something they might have read. When I asked Sergio what he thought was causing his pain, he did not miss a beat. Lung scarring, he told me. He wanted to talk about the potential long-term effects and if this would lead to a serious disease. As the physician worked through his list of concerns, reassuring him along the way, he'd push back. Yeah, I understand, but he'd circle back to something else he'd read. He had it pulled up on his phone. He could show us. The problem with online information is that it's often out of context. Internet searches identify rare or worst-case scenarios. Misinformation and misinterpretation often go hand in hand, and it's hard to navigate this space alone. Caring for vulnerable patients requires trust, comfort, and thoughtful communication to alleviate the anxiety patients often feel in these scenarios. Teachable moments in clinic are an opportunity for these values to shine. The physician I work with is really good at teachable moments. I watched her pull up images on her computer to show patients exactly what she's talking about when referring to anatomy. With Sergio, I watched her do what his online searches couldn't. I listened as she connected his medical history and his story to his current symptoms. I followed along as she walked us through her line of thinking. We found out that he's not usually that active, and swinging a hammer in that manner was a new motion for his body. Most importantly, we were able to pinpoint a muscle group that aligned with where he felt the pain. To his visible relief, it was not his lung. We no longer have a stronghold on medical information, but we have the skills of empathy, connection, and context. The ability to assess, interpret, and contextualize signs and symptoms is a gift. For Sergio, it provided the reassurance he desperately needed in that moment. Teachable moments in clinic can build trust for patients and medical students alike. It's moments like these that engage patients in their care and rebuild the foundation of trust and partnership. In 2 weeks, I'll be starting my second year of medical school. It's unlikely that I'll see Sergio again, but this experience has stayed with me as an example of the importance of misinformation and teachable moments. I hope it has stayed with him too.
As someone who's interested in primary care, I'm told all the time that an equal part gratifying and terrifying thing about the field is its breadth. What are you supposed to prioritize when a patient has comorbidities? What's your scope? Do you know that you'll only have 15 minutes per patient? Yet despite all these potential challenges, one experience taught me that sometimes expanding your scope, going off script, and maximizing your time is where change happens and where trust grows. During my third year of medical school, I spent some time in a geriatric primary care clinic, and one patient, who we can call for the sake of the story Miss Marshall, was a woman in her 80s who's being seen for a routine checkup. Together, she and the attending physician discussed her hypertension, her diabetes, her cholesterol, and then the conversation approached mental well-being, and the attending inquired about her mood. Miss Marshall looked momentarily taken aback before saying, "Actually, I just feel so anxious all the time. I worry about everything. It's constant, and I don't feel myself." The attending paused her documentation to turn to the patient. "Tell me more." Miss Marshall went on to reveal that lately she'd been worrying about her children and grandchildren more than usual for no apparent reason. She felt like she was the caretaker of the family and owed them her undivided attention at all times. "It sounds like you've been struggling," said the attending. "There are options we can talk about. Therapy, medication." "No, I don't want medication," Miss Marshall interrupted. Her response was firm and immediate, and I could see the attending's head tilt in concern. "Can I ask why?" "I read on Facebook that it makes you crazy," Miss Marshall said. Her hands started to tremble in her lap, and I watched the attending reach over to gently hold them in her own. "Anne changes her personality, and I don't want all that. I don't want to mess with anything. I'm not weak. I can handle it. I don't need meds." I watched the attending pause to digest this new direction the conversation had taken, and I could tell this was a delicate moment. It was clear that Miss Marshall trusted her physician enough to disclose personal matters about her mental health, but yet not enough to let the physician's recommendations overtake her belief systems. The path forward hinged on whether or not the attending to acknowledge this new direction, and she did. "Let me ask you something," said the attending. "Do you take medication for your diabetes and your high blood pressure?" Miss Marshall looked bewildered. "Yes, of course." "Do you believe those medications are helping you get better?" "I do." "Did you hesitate to start medication for those issues?" Miss Marshall was silent, as if she began to understand where this was going. "No, I suppose I didn't hesitate." "Then why," asked the attending, "should your mental health be any different? Why should you treat it less urgently than your diabetes or your high blood pressure?" And what followed was one of the most impactful moments I can remember throughout my whole medical school journey. I can still vividly see Miss Marshall's face in my mind as she registered those words. It was as if a veil had physically lifted and understanding dawned on her face, and she began to cry. "You're right," she whispered. I don't know why I thought that. Meds won't make me weak and I need help. In this single encounter, the attending was able to combat not only misinformation, but stigma as well. To me, this represents the importance of shared decision-making as a tool for addressing misinformation and strengthening trust. It's important that clinicians present multiple options to patients in order to elicit their preferences as well as their hesitations. Sometimes this can be as simple as reframing patients' priorities, such as, is anxiety any different than hypertension to you as a medical concern? Or even digging deeper into patients' views to create space for education, such as, what is your understanding of what antidepressants do to the body? It was heartwarming to think that not only did Miss Marshall choose to receive care for an important issue, but she may eventually correct someone else in her life who once shared her former perspectives. So to go back to my earlier point, when someone asks me, what would you prioritize? I think my own answer would be, I want to prioritize where the patient leads me. Because letting a patient rant for a few minutes about how they struggled to make the bus to their appointment can help their doctor realize that, hey, maybe the physical therapy center 10 miles away really isn't the best option for their rehab. Clinicians should listen to what patients say and don't say. Observe their patellar reflex, sure, but also other reflexes that have been conditioned by stigma. Clinicians can unknowingly contribute to the spread of misinformation by not allowing space to have these critical discussions with patients, by keeping treatment options non-negotiable and rigid, and by choosing not to explore patients' inner lives and what helps them make decisions. A patient's anger or indignance is not necessarily an invitation to close the conversation, but to probe deeper, gently, with purpose, and help guide them to a healthier point of view if need be. With each conversation, not only will trust hopefully grow, but so will patient empowerment, which is a win for everybody. Thank you.
So my bet is that those of you who don't have the opportunity to work with medical students are feeling really jealous right now. You all did an exceptional job in delivering your stories, but more importantly, your insights were really so great for someone so early in their career. So I wanted to start off by asking, you've all experienced, whether it's this particular incident that you talked about or others, some really challenging issues that medicine is facing. Do any of those experiences that you've had already either give you pause in terms of pursuing a career as a physician? And please comment on why or why not. And I'm going to start with you, Meher.
Yeah, so I think this is an interesting question, kind of a loaded question. I think it's natural to have doubt. We're so early in our careers that I think we still have a lot that we'll have to overcome. But I think even with the doubt, I just finished my first clinical rotation. And I feel like what stood out to me over all those difficult situations was the privilege of getting to be invited into someone's life. And there are very few other fields where you get to have that kind of connection with someone. And so I think even with the difficulties and the doubt and the challenges, I think that there's pretty much nothing else like it.
Molly, maybe you can also answer this. I saw your beautiful family. You really are a super person, not only matching successfully at a prestigious program, but also it looks like you just had a baby in addition to the son you referred to. So if you could comment a little bit, because obviously you're having deep thoughts about your career and balance and what medical school experiences have made you think about.
Absolutely. And I have a wonderful partner, which helps, obviously. But I guess I would start by saying I think there are a few rational folks who could make it through medical education without having some healthy doubts. So I think, as you said, that's very normal. I think that for me, what I do with those doubts is really the important thing. I think, one could go one of two ways. Either those doubts could make you become disillusioned and jaded and feel as though it's not worth it to be a part of this system. Or those doubts could make you recognize how vital and important your work is and your perspective is, and the direction you feel like you could help incrementally budge things. So I think the answer is yes, it does, and it probably should give us pause, but that should make us work all the harder to try and make things a little bit better.
Thank you. I'm going to switch us to a different question now. When you reflect on your education itself in medical school, what do you think is particularly important for students to learn in order to address these issues of misinformation that you also saliently experienced later on in your med school time? And what particular attitudes and skills are important, and maybe you could share a little bit about how they were taught or how they were not taught where you were. I'll start with you, Isra.
Yeah, so I think a lot about the previous presentation we actually had about patient stories, and how a big common theme that I noticed was the issue of communication and listening in particular. And I feel like one thing I've been very fortunate to have in my medical education is a very firm emphasis on communication and transparency between patients and providers. And during our first few years of school, I remember there were, scheduled sessions we'd have with standardized patients where the main focus was, delivering bad news or encountering stigma about vaccines or something really challenging. Mm-hmm. And I was pretty uncomfortable, not gonna lie, to, engage in those conversations, but that's where I felt I had, the steepest learning curve. Is I took a lot away from those practice sessions, and the standardized patients gave a lot of feedback about, as patients themselves, what would they most like to hear from their doctor in terms of a healthy, transparent relationship and how to really foster that. So I think, what those sessions have taught me, that there's an interesting question I know about whether you can teach compassion, and I don't want to get into that here. I feel like that would take a long time to answer, but I think there are certain tools of compassion that you can probably convey in medical school education. And so I feel like that's a really great starting point as a student.
Elina, you're probably right in that early kind of foundational communication skills part of your medical school career. Can you comment a little bit? And one question is and this will go to all of you if it's not true for Elina, have any of you specifically been taught how to communicate around the issues of misinformation?
So we didn't have it specifically on misinformation, but we did have a training as part of our STARS initiative on guideline-based care and how do you talk to a patient if they're requesting something that's really not indicated for them or you don't necessarily think they should get. And that was a really interesting moment because our class was in some ways divided on would I even advise against this? As first-year medical students, we're still trying to understand the literature ourselves in some ways. So having those conversations, hearing what your classmates say, but also having this practice moment of how do you talk to a patient and how do you talk to a peer if you don't necessarily agree with their prescribing practices or where they're headed. And I think that was a really beneficial moment that should be carried over for misinformation as well. So if you do have a patient coming in with similar concerns, and how do you take what you know and distill it into accessible, non-judgmental, toneless communications? And how do you keep pace when it might be the 8th time you've heard that question today, but it's the first time that particular patient has asked? It's like they still need the empathy and compassion that you had for your very first patient that asked you that.
Anybody else?
Yeah, I think I had a similar experience. I don't think we had a specific dedicated session to misinformation, but it's built into some of our practice sessions like vaccine hesitancy and things of that nature. But I think one of the things that I've learned more from being on the wards is being willing to admit when you don't know something. I think that's something that I thought first, second year medical school, we learn the right answer. We're always going to know what's going on with the patient. And just from my brief experiences on the wards, I've already learned there's a lot of ambiguity, and that a lot of times patients actually appreciate when you say, I'm going to go look that up. especially when it's something that they deeply believe, instead of just immediately shutting them down and saying, well, that's not what I learned in my class, so that can't be right. You know, there are a lot of things that I've learned from looking things up after a patient tells me something that they know.
And sometimes even then you don't necessarily know the answer, right? And so
That's been the hardest thing. I really didn't realize how many times we just don't know.
Yeah. Well, that's as Rich alluded to earlier, there is a current foundation grant effort underway looking at how to teach uncertainty, and obviously medical students are part of that. So do you, any of you have anything else? I was surprised to hear, actually, Meher, that you said you did have a standardized patient case around vaccine hesitancy?
Yeah, we've had different kind of small group discussions and things throughout both our preclinical years and then practicing with standardized patients.
Okay. Anybody else? Okay. And then, well, I think we have time for one last question, and I would love to ask you all what your perception is about how your generation of young physicians can engage with social media to help address some of the concerns you've already, we've been talking about at the first session and in the forum in general around misinformation.
Yeah, I think social media is proving to be a very up-and-coming popular communication tool between, physicians and the general public. I think there are a lot of ways it can be used responsibly, and that we've probably seen other ways in which it can perpetuate harm and misinformation itself. And really grateful that our generation has more of an opportunity to familiarize ourselves with social media and kind of learn its advantages and disadvantages.
I know at our medical school we have a lot of policies about how not to use social media. We are starting to be a little more progressive and think about how we encourage students how to use social media. I'm curious what is the case at your schools?
I don't think we're very active on social media as a school, but I got a master's of public health, and my public health program has really great Instagram stories where they do target, honestly, a younger demographic of patients who might be following them on Instagram or potential future students. And they've been getting repeated a lot, retweeted, and they're really phenomenal. And I think in general, as a medical student, I've benefited from social media in terms of finding new articles that I would have probably not come across unless the Instagram magical algorithm or Twitter would have spit them out for me. But I do wonder where the space is for engaging patients there, because people don't often go to check sources unless they're reading the initial paper, and the initial paper is usually like med Twitter, and you're targeting other physicians. You're not necessarily targeting patients by sharing primary literature. And even if you are, it's really hard to interpret it by yourself. Like, we've all gone through school to learn how to read an academic paper, to understand what an odds ratio is. And unless we're preparing people to also engage with that literature directly, there is potential for misunderstanding it, misinterpreting it, or having it be skewed in a way that was not intended by the authors. So who's responsible for digesting that information for others?
As someone who still struggles to understand what an odds ratio is, I think the challenge for our generation of physicians who have been kind of deemed those with greater facility with social media is to figure out how we can create that community, both with our colleagues and with patients. I think sometimes social media has a tendency to really be a tool folks use maybe to cultivate celebrity. And I think that as physicians, if we can think about how to create those nodes of connection, if we can think about how to create a place for conversations that are really fruitful and informative and valuable to patients, we will have, one, totally revolutionized social media, but also I think that would be a really effective way to use it as a tool.